Thank you for the opportunity to participate today. As I spoke earlier, my name is Dr. Marc Belitsky. I'm a chiropractor. I'm board certified in chiropractic rehabilitation. I'm the owner of an integrated healthcare practice that employs physical therapists. I'm speaking today on behalf of the Pennsylvania Chiropractic Association. I work alongside physical therapists, and firsthand, I see the value that physical therapy brings to our patients. This is not an argument against the profession or against modernization. We are not here to oppose another profession's advancement. We are here to ensure that every expansion of clinical authority is evaluated under the same evidence-based framework and supported by training, demonstrated by competency, and patient protections commensurate with the responsibility being granted. Pennsylvania currently allows physical therapists to evaluate and treat patients without a referral up to 30 days, as you know. This provides meaningful access. It also allows care to begin, gives physical therapists a time to monitor the patient's response, and establishes a defined period for treatment without referral. The proposal under discussion would extend that period from 30 to 60 days while also, this is important, removing existing requirements related to clinical experience and continuing education for direct access practice. Doubling the period of independent authority while removing the experience and continuing education requirements that currently support it should require a clear evidentiary justification. The committee should ask 3 straight questions. Why is the increase from 30 to 60 days necessary? What access or patient care problems exist under the current 30-day framework that the additional 30 days would solve? And what benefit does the patient receive from the extending the statutory period before referral or involvement by another authorized provider is required? As a portal of entry provider working in musculoskeletal care, I understand the independent access involves more than just beginning treatment. It includes determining whether care remains appropriate, recognizing when clinical picture has changed, and knowing when a broader evaluation, consultation, or referral is necessary. Patients do not always arrive with a clear diagnosis. Symptoms may change, pain may fail to improve, a condition that initially appears routine may ultimately require imaging, additional diagnostic evaluation, consultation, or referral. This is not a judgment about the ability of individual physical therapists. It's a question on whether the statutory framework maintains the appropriate relationship, access, preparation, independent authority, and patient protection. Before extending the current period, the committee should have a clear evidence that the change is necessary and that the education, competency, and safeguards supporting it are commensurate with the increase in the responsibility. Improved access is an important goal, but access should not be measured only by how quickly treatment begins. It should also be measured by whether the patient receives the right evaluation, reaches the right provider, and is referred at the right time. We are not asking the committee to reject modernization. We are asking the committee to apply one consistent standard. Expanded authority should be supported by evidence, proportional preparation, demonstrated competency, and meaningful patient protection. Thank you for your time and careful consideration. Chairman Burns, again, thank you, and thank you to the whole panel. The PCA, the Pennsylvania Chiropractic Association, approaches dry needling similar to how we did with the extension of the scope in a neutral framework. We are not arguing that physical therapists should never be permitted to perform the procedure. We are asking whether the education, hands-on training, demonstrated competency, and board oversight are commensurate with the authority being granted. The answer does not have to be no. The answer should be show us the standard and don't let it be vague. Be very specific. Dry needling involves inserting a needle through the skin and into the underlying tissue. Safe performance requires knowledge of the anatomy, needle depth and direction, neurovascular structures, contraindication, infection control, patient selection, complications, recognizing these complications and the appropriate response when a complication occurs. The anatomy does not change based on the practitioner's license. The obligation to demonstrate proper preparation and competency should also not change either. The proposal requires the completion of a board-approved program, but it does not clearly establish how many hours of the education are actually required, how much training must be supervised and how much is hands-on, how individual competency will actually be demonstrated, whether an examination or practical assessment will be required, or how the board will verify that each practitioner is actually qualified. These are not minor administrative details. They are the standards that connect clinical authority to patient protection. Program approval is not necessarily the same as an individual competency. A board may approve a course, but an individual practitioner treats the patient. The individual should complete defined preparation and demonstrate the ability to perform the procedure safely. The PCA applies the same principles to its own modernization proposals. We have supported defined education, hands-on preparation, demonstrated individual competency, and board accountability. We accept for ourselves the same evaluation framework we're asking the committee to apply here. The committee should ask, and I actually have a question, is that according to the committee, we're looking to expand into dry needling, but what I'm listening to today is that it's already being performed. And I would ask, how is that being done? What are the preparation and the commensurate with, what preparation is commensurate with this procedure? How much is supervised hands-on training is necessary? How will we, as practitioners, demonstrate competency? What safeguards ensure the complications are recognized and managed appropriately? We don't want vague. We want the commission and the committee to have very specific answers to these. We're not asking the committee to favor one profession over another. We're asking that every profession seeking the authority be evaluated through the same core patient safety questions and held to clearly define competency standards commensurate with the procedures. The anatomy is the same. The risks are the same. The obligation to demonstrate preparation and competency should also be consistent. Thank you.
Well, thank you all for your testimony. I got to tell you, this is one of the best hearings we've had. Just the conversation from both sides and the back and forth. I can say I see both sides of this issue. And when that happens, that means there is some form of compromise that can be had. We just got to figure out where that is. And that's what this testimony will be used for, is to see where we can find some agreements, where we can find compromise, not only among the groups, but also among the legislators as well. And there was a lot of talk about educational standards here today, and I think that's where the compromise may lie, if there is to be one. But how do we get there is what we have to discuss over the next couple months to figure that out, if we can get there. But thank you all for coming today. And like I said, this is one of the best hearings. Thank you.
Thank you.
And we're adjourned.